Our next speaker is Dr. Wanumkarng of Bangkok, Thailand. He's a very outstanding endoscopic DCR surgeon. In fact, I heard he had got an idea to learn meaning of the trick and how to do very basic endoscopic DCR operation. Probably a bit biased, but I think Dr. Wanumkarng will be able to show us now how you use the 40-degree endoscope to do that. Thank you very much.
Thank you very much, Dr. Shu. Today, I would like to share with you about the technique that I have used in my practice. This is the video that shows the 3 dimensions of the patient. And sometimes when we do the surgery and we could not imagine how is the bony osteum that we did. But if we can do the CT scan in every case, that's going to be easy for plan the surgery or do the revision. But in this case, it shows that on the right side, the bony osteum is too small. And on the left side, the bony osteum is adequate. In my series, I have a small series that I have reviewed 10 years ago. In 2004, that I have started, and about 692 case surgery that have been done. But accumulated for the success rate is not that good initially because initially the learning curve is so not that high, and the skill is not that so good. So the failure initially is about 80 to 90%. And fortunately, I have a good chance that all the failed case that I have done or the other people done, I have reviewed by my own. So overall success rate is only 92%. So all the cases that I have reviewed, I have learned a lot. So it's a good point that we learn from our mistake, and we sometimes when we review, we find some concept. This is the video show that the ideal in the middle part is the ideal osteum that we should do in every case. And this is a too small osteum. And for the whole revision case that I have done, I have found that approximately 84 to 89% the fail reason because of the bony inadequacy. And how can we estimate the adequacy of the bony osteum intraoperatively or after the operation? And let me show you. This is a test that I call 45-degree test. I divided and subclassified to be 45-degree up and 45-degree down. 45-degree up is mean we bend the proximal part of the Bowman probe down, so the tip of the Bowman probe come up. So we call 45 up. And then we can rotate the proximal end of the Bowman probe up. So the tip going to be down. So we call 45-degree down. So this is the diagram. We all know that the area of the bone, especially above the horizontal plane, at the common caniculi and the topmost of the fundus is about 3 or 5 millimeter. That's a point. That's an important point that we should remove the bone overhead over that area about 3 to 5 millimeter to optimize the opening. If you are the beginner, you go to the anatomy and you use a pen light and put in the skull. So you going to be familiar about how thickness it is for the frontal process of the maxillary bone. Most of the time, the lacrimal bone is not going to be the problem because it's thin bone, but the most problematic part is the frontal process of the maxillary bone. This is a 45-degree test at the 0 degree. The pink area shows the area that expected bone that should be removed properly. And I would show you step by step by the 0 degree. And then if the tip of the Bowman probe pass at 0 degree, negative is mean could not pass through the medial aspect of the lacrimal sac. If it positive, it means it could be passed through the pink area and touch at the septal mucosa. And then 45 degree up It means that the negative is could not be passed through the lateral wall of the lacrimal sac. It's a positive, it means the tip could be passed to the area of the removable bone and touch at the topmost of the septal mucosa. And this is the video show how to perform and how to use the 45-degree test in 2 seconds intraoperatively. The first step, all we do the remove at the lower 2/3. This is if conventional, we just when I was started to do, I remove only the lower 2/3. And this is the video show at 0 degree. And when we gonna remove the upper 1/3 of the bone, I always use a 4mm chisel and the mallet technique for removal. And you can expand the finger widely like that, so we can grab the chisel firmly. And do not grab like this because it's gonna be not firm and not steady. So we divide the bone to be 2 parts. The first part is lower 2/3 and the second part is upper 1/3. With the vertical cut like there and another horizontal simple cut, we can remove the upper 1/3 of the frontal process of the maxillary bone easily. And then it's like a hinge rotate, and then we can grab it easily. This is like a basic case that we perform in our routine endoscopic DCR. You can see that the bone is quite thick. If you can open the bony ostium like this, the percent gonna get the very high success rate could be achieved. And then we can do the 45 up. You can see the tip of the bone probe could be passed through the area of the removable bone and touch to the septal mucosa. This one is called 45-degree test up positive. And in some condition, if you are the beginner, you can use this one practically. And the next step, we can open and can see the whole part of the medial aspect of the medial lateral wall of the lacrimal mucosa. Okay, and the next one is a 45-degree down. The 45-degree down is have been termed for evaluating the lower 2/3 of the frontal process of the maxillary bone. Another benefit is the degree of the scar tissue in the revision surgery. Let me show you. If the negative, it could not be passed to the from the medial part of the lacrimal sac. But if it's positive, it could be passed to touch the tip at the septal mucosa. This is show the okay, and then I can divide to be the 45-degree down test negative, soft negative, and hard negative. The soft negative is mean in this case they have the problem with the fail with the sum syndrome. When you put the tip of the bone probe down 45 degree and you can touch the softly, you can feeling let the soft touch. So that's mean the bone from the previous surgeon pretty good for remove adequately. So we have to remove do the bone job again. We just create the simple vertical cut and put the posterior flap back posteriorly, and then with the one simple suturing that could create the for and achieve for the revision surgery. That's one we call soft negative for the 45-degree down test. And next one is a hard negative. What is the hard negative? The hard negative is mean when we try to use the bone probe up at the proximal part and the tip of the bone probe down, we could not we're gonna get the very hard time to use the tip of the bone probe passing through the area, and this video show I got a very hard time to penetrate through the nasal mucosa. So at the 0 degree, I have a very hard time also. So that's represent that inside it may have the very thick scar and very thick bone. So in 2 seconds, we can keep in mind that in this case, we tell our assistant that we're gonna have a big job. We have to do the whole bone job and flap job. So when you do the surgery, we can see from the surgery, when we will make a vertical cut, we can see that we have seen very, very thick scar tissue. And at this point, sometimes they have the very thick bone and very thick scar. So that one it helps us to evaluate and plan of the management and tell the patient about the prognosis for this case. And this shows the same technique that use chisel and the mallet for removing the bone. And finally, I measure some small piece of the bone and collected. In my record, I have selected in the case that we can got about 248 operation, female about 82% and male about 17%. The average bone volume for the male is about 0.33 millimeters, and the female is about 0.32 millimeter. It's no difference between the gender for the amount of the removable bone. But I think this number gonna be guide for the beginner. If you are the beginner and you started to do the endoscopic DCR and use this concept for guided for how you're going to remove the bone. If you remove the bone about 0.5, 0.6, 0.7, and that can represent that you may be too much remove of the bone. But if you remove the bone and you collect it, it's about 1.5 or 1.6 millimeter, that's going to be something represent that we should remove a little bit more for the bone removal to get the adequacy of the bone. So by conclusion, the 45 test is a quick and effective test that could be done in 2 seconds and could be evaluate the adequacy of the removable bone during the primary DCR and could be evaluate and used for the degree and the cause of the fail in the revision surgery. Thank you.
Excellent idea. May I ask a quick question?
Yep.
45 degree up more important or 45 degree down more important?
I think both is important, but the point is the up 45 up important for the if you want to get close to 100%, 99.9%, you can get the use the 45 up. But for the revision case, I think in the first part of the surgery for revision, if we use a 45 down, it's gonna be let us can plan for the management during the first half of the surgery.
But the size of the sac is different.
Right.
I know you're talking about going up is to expose the whole top of the fundus. So the size of the sac is different from patient, and you need to always stick to 45 degrees.
No.
Or when you see the fundus, the top of the fundus of the sac,
yeah.
it's good enough. It may not be.
Right. Actually, the name is just a name,
Okay.
but the concept is about 3 to 5 millimeter. Yeah.
I thought you were talking about using
Yeah.
45 degrees.
Sometimes the name may be not so important. The amount of the height. Yeah. Thank you.